to Canine Sports Medicine. Can you all see the slide?
Yes, sir.
Yes, sir.
Okay, great. So I did it right this time. We'll talk about some common injuries and treatments. Realize our time, we can't go over all of the different injuries and treatments, but we want to review the most common sporting injuries of the forelimbs and the pelvic limbs and briefly discuss some of their treatments. Now, one of the things that will actually be the most beneficial is to prevent the injuries. And so, like any sport training, if you don't train properly and you don't have proper conditioning, you're going to be more apt to sustain injuries. And the same is true with our canine patients. So we have to have adequate cardiovascular conditioning because that will help to prevent fatigue. And just like us, if we exercise to our limits and we're very fatigued, we become a little bit uncoordinated. Our muscles are not able to control our joint motion, especially at higher level activities, speed activities, and we're more susceptible to injury when our muscles begin to weaken. So that also will result in increased concussion on joints and actually abnormal motion of the joints, and it may make them more susceptible to injury. So having a properly trained and conditioned dog will be very important to help prevent injuries. Now, with that as an introduction, let's talk about some conditions that we'll be discussing today. The forelimb. As with almost any musculoskeletal discussion, osteoarthritis has to be at the top of the list. Osteoarthritis is so common, it affects up to 60% of adult, medium, and large breeds of dogs. And a lot of the conditions that we're going to be talking about will result in secondary osteoarthritis. But more specifically for sporting injuries, the shoulder is an area that is quite susceptible. We have a number of conditions. Pretty much any muscle surrounding the shoulder is susceptible to injury. So the biceps muscle, we can get biceps brachii tenosynovitis. We can get medial shoulder instability, which can be a combination of injuries to the medial glenohumeral ligament or the medial collateral ligament, the subscapularis muscle, and in the most severe forms, joint capsule injury. Supraspinatus tendinopathy or insertional tendinopathy can be an issue, infraspinatus muscle contracture and or ossification. And sometimes, although it's fairly rare, we can have a myopathy of the teres minor muscle. Certainly, like any sports discussion, sprains and strains can occur. These are often fairly mild and they're self-limiting, and often the dogs never get to the veterinarian because with a little bit of rest and ice, they seem to get better on their own. So we tend to see only the ones that are chronic injuries or that just don't get any better. Carpal hyperextension is unfortunately a devastating injury that we see not only in sporting dogs, but any dog. And so we'll discuss that, as well as some muscle injuries and foot injuries. In the pelvic limbs, again, osteoarthritis is one of the most common things we deal with in all dogs, as well as sporting dogs. But rupture of the cranial cruciate ligament is probably the most common thing that we deal with overall with sports injuries. Hunting dogs, protection dogs, service dogs, those types of things. Patella luxation is less common in larger sporting dogs, but certainly is an issue in the smaller dogs, although it can be an issue in larger dogs as well. And again, sprains and strains and muscle and tendon injuries. So as we mentioned, osteoarthritis is probably the most common condition of sporting dogs. Anytime you have a dog that has abnormal joint biomechanics, then the dog will have secondary osteoarthritis. So we're talking about hip or elbow dysplasia here. It can also occur as a result of injury, especially excessive, sprained ligaments, or as a result of excessive concussion, doing a lot of jumping and so forth. And then, of course, cranial cruciate ligament disease is probably the most common thing that we deal with sporting dogs. And of course, medical treatment, as well as some of the rehabilitation techniques that we talked about yesterday, and therapeutic exercises, they can have a profound effect on managing arthritis in sporting dogs, as well as any pet. So we really want to incorporate rehabilitation techniques in addition to non-steroidals, joint supplements, and so forth. So let's start off with the shoulder joint. This is a condition that's relatively common, Biceps Tenosynovitis, and it can range from relatively mild lameness that's intermittent to a fairly severe lameness where the dog almost looks like it has a fracture or a radial nerve problem, such as the dog that we see here. So biceps tenosynovitis is an inflammation of the biceps tendon sheath and or the tendon itself. Remember that the biceps tendon sheath communicates with the shoulder joint. So anything that happens in the shoulder joint, that joint fluid will get into the biceps tendon sheath. Oftentimes there's some type of trauma to the bicipital tendon, either excessive pull on the tendon, which may damage the tendon fibers, or as I mentioned, if we have chronic inflammatory disease in the shoulder itself, those inflammatory mediators can work their way up to the biceps tendon and cause secondary inflammation of the area. When we have chronic repetitive injury, we can have partial tearing of the tendon, and the body's response is to try and repair that with scar tissue and sometimes with dystrophic mineralization. When we have indirect trauma, such as pull on the tendon, we can have fibrous connective tissue that develops between the tendon sheath and the biceps tendon itself, and that can create adhesions between the tendon, and that can cause quite a bit of pain. So when we look at the origin of the biceps tendon, it comes off the supraglenoid tubercle of the scapula, and it goes across the shoulder joint and goes medial to the greater tubercle. So we have a lateral view here, and you can see that the greater tubercle is more craniolateral, and that biceps tendon runs right in that tendon sheath, just medial to the greater tubercle. So the condition typically will affect medium to large sized dogs. They're usually middle-aged or older, no sex predilection, but it's more common in working and active dogs. And I think I see this more in hunting dogs in the fall when there's a lot of rain and the ground is soft with a lot of mud, and these dogs are picking their legs up out of the mud all day long while they're hunting. And if you think of yourself, if you do a lot of biceps curls, you're going to get some pain with the biceps muscle and tendon insertions. And so I look at it like that. They're doing a lot of repetitions, lifting their leg out of this resistance provided by the mud, and it can be a repetitive use injury type of trauma. So dogs often are intermittently or progressively lame. Usually the lameness will worsen after exercise. The owner may suspect that there has been some inciting trauma, but oftentimes there's no recollection of any injury to the leg, and usually there's a slow onset of clinical signs. Radiographically, we don't see a whole lot unless we see some enthesiophytes or sclerosis of the bicipital groove, or sometimes we can see bony resorption of the supraglenoid tubercle, and that usually indicates a very chronic strain at the origin of the biceps tendon. This is the maneuver that we can use to help us exacerbate the stretch on the biceps tendon. Now remember, the biceps muscle is one of those muscles that crosses two joints. It crosses both the shoulder and the elbow joint, and it causes extension of the shoulder and flexion of the elbow. So with those maneuvers of the joints, the muscle shortens. If we want to exacerbate the tension on the muscle, we do just the opposite. We try to stretch the muscle and the tendon maximally. So to do this, we want to flex the shoulder joint and then simultaneously extend the elbow. Now, in a normal dog, you should get the antebrachium and the paw pretty much to the back of the dog, to the dorsal region of the dog. But if you can't get it that far, and if you have pain while you're doing the maneuver, that strongly suggests that we have inflammation of that biceps tendon. And when we palpate the biceps tendon, again, we want to go medial to the greater tubercle. And sometimes while doing that biceps maneuver, flexing the shoulder and extending the elbow, and placing simultaneous pressure on the biceps tendon in that region of the biceps groove, we can exacerbate the pain. So ultrasound can be used to provide a definitive diagnosis and also give us some idea of the severity of the biceps tendon injury. I've not found MRIs to be that useful just because they tend to underplay or downplay the significance of the lesion based on the size of the tissue and the size of the slices that the MRI is taking. So ultrasound is probably a bit more sensitive tool to diagnose this condition. When we look at a radiograph, there are a couple of things that we may see. If you look where the arrow is pointing on the left-hand side here, you can see some white densities, and those are areas of sclerosis in the bicipital tendon groove, and sometimes we also have enthesiophytes. If we look at the medial region of the shoulder joint, you can see that the medial joint capsule has been cut away, so we can see the lateral glenohumeral ligament. But what we're also seeing is the extent of that biceps tendon sheath. And there's also a transverse retinaculum that helps to hold the biceps tendon in place. So you can see that the shoulder joint communicates with the biceps tendon here, and that's the extent of where it runs. This is a very chronic case of biceps tenosynovitis, and the dog also has a lot of other arthritic problems in the entire shoulder joint. But what I wanted to point out here is the sclerosis in that area of the biceps groove, and also a little bit of resorption of the supraglenoid tubercle. We can do a skyline view to highlight the biceps tendon groove. So if we put the dog on its back and aim the X-ray beam right down that bicipital groove, we can highlight that to look for any enthesiophytes. So you can see here in the biceps groove proper, that's the area of the biceps tendon, but we don't want to confuse it with number 2. Number 2 is actually the supraspinatus tendon, and this particular dog has some calcification of that supraspinatus tendon. So even though the two structures are very close together, they are distinct, and we can identify them on a radiograph using this particular view. Now, one of the things, sometimes we'll get some pain with internal-external rotation of the shoulder joint if we have a supraspinatus problem like this, and we may cause impingement on the biceps tendon just because of the location of the two structures being so close together. So be aware of that there could also be simultaneous supraspinatus problems. A lot of these cases in their early stages could be managed conservatively with rest and anti-inflammatories, but usually in advanced cases, this is not as effective. Most of the cases that I see already, the rest and anti-inflammatories have been tried, and the dog still remains lame or becomes lame again after reinitiating treatment in sports. So we have to move on to something a little bit more aggressive than just anti-inflammatories. So the first choice, if we ultrasound the biceps tendon and we find the fibers to be primarily intact, but maybe a little bit swollen, maybe we have a little bit of increased fluid in the tendon sheath, we can use a more conservative approach. And the conservative approach that we use is to inject either platelet-rich plasma or adipose-derived stem cells into the lesion using the ultrasound to help us guide where to inject the cells or the PRP. And what that's going to do is jumpstart healing, because the stem cells and the PRP are very rich in growth factors, and they'll really help to stimulate the healing process. But we have to rest the dog adequately to allow those tissues to heal again and for the inflammation to settle down. So usually that means about a 3-month restricted activity period, and then slow return to exercise using appropriate therapeutic exercises. So usually we'll inject 1 to 1.5 cc's into the lesion. We can repeat this monthly until healed. And most dogs that have mild disease will have a very good to excellent outcome. And if the condition is severe enough, or if they keep re-injuring the tendon, then surgical intervention could be performed. Now, I think the most memorable case that I had was a dog that came to me. This is a very high-level field trial dog that was seen by another excellent surgeon who recommended doing a surgery on the biceps tendon, basically releasing the biceps tendon. But the owner was not interested in that because she'd had a previous dog that didn't do so well with that procedure. So she came to us for stem cells. And when we ultrasounded the dog, there was probably about a 90% tear of the biceps tendon. I really gave her a pretty poor prognosis for stem cells being able to heal that. But she was quite insistent, and we did monthly injections of stem cells for about 5 months. And believe it or not, it actually did heal quite a bit. And in fact, the dog was able to go back into field trial competition. And the first trial that it entered, it got second place. And then it went to the nationals later that year. So I'm not going to say every case ends up that way. That was a bit of a surprise. But nevertheless, sometimes these types of treatments can give pretty good results. Now, the surgical management of biceps tenosynovitis, if we need to get to that point, probably the most common thing is to go in and release the biceps tendon from its origin on the supraglenoid tubercle. And we can do that arthroscopically. If it's a sporting dog, I'll tend to do a tenodesis to the proximal humerus. So I'll take that cut biceps tendon and then use a screw and a spiked washer to hold the tendon in its new position in the proximal humerus. But a lot of dogs, the tendon is just released. It sort of develops a soft proximal attachment to the end limits of that synovial sheath, and the dogs can perform quite well with that technique. We have a lot of injury to the rotator cuff muscles of the shoulder, and the dog shoulder primarily flexes and extends. It's not like a rotator cuff in a person where we need to do a lot of supination and pronation of the shoulder joint. The most common activity of the dog shoulder is just simply flexion and extension. And we have both passive stability mechanisms as well as active stability joint mechanisms. Now, the passive mechanisms are the solid structures like the medial and lateral glenohumeral ligaments or collateral ligaments, the joint capsule, the conformation of the joint, in other words, the rounded end of the humeral head, and then the corresponding glenoid cavity, that helps to provide stability. And then the actual synovial fluid will provide some cohesion between those two cartilage surfaces and help to keep the shoulder in position. The dynamic stability is provided by all the surrounding muscles, including the biceps, the subscapularis, the teres minor, and the supraspinatus and infraspinatus muscle. And we can have injuries to all of those dynamic stability rotator cuff muscles. And it's the active contraction of those muscles that help to provide compression of the shoulder joint, as well as increased tension of the joint capsule to provide more stability. So when we look at the shoulder joint, and if we look at the diagram on the left-hand side, we can see that the lateral joint capsule has been removed, and we're looking at the medial joint capsule, and in particular, we're looking at the medial glenohumeral ligament. What you see is kind of a Y shape. There's a craniomedial band and a caudolateral band, and so they come together and form kind of a Y, and then they attach together in the proximal humerus. And the medial shoulder instability syndrome often has damage to the medial glenohumeral ligament, especially that cranial band of the ligament. The lateral glenohumeral ligament, as shown on the right-hand picture, is less commonly injured, and that's just a solid structure with no Y shape to it. So I think we're diagnosing more and more medial shoulder instability because we have a greater awareness of the condition. Also, we're doing more arthroscopy so we can see what's happening with the structures in the shoulder, even with very mild injuries. And when we consider what dogs are doing these days, a lot of the sporting events create a lot of stress on those stabilizing structures. As we mentioned earlier, dogs are primarily meant to run in a straight line. But when we have them doing sporting activities, such as protection sports, where they're jumping up and attacking the guy with the padded suit, and they land funny, they're putting a lot of torsional stress on the forelimb when they land in an awkward position. when they're doing agility competitions. They're jumping over a jump at full speed, and they're turning in midair to go to the next obstacle. And when they land on that single leg, while they're turning, there's a tremendous amount of torsional force on that shoulder joint. And so we're seeing a lot of these injuries as a result of those types of high-speed torsional shoulder activities. And the most common structures to be involved with those sorts of activities are the medial glenohumeral ligament and the subscapularis muscle and tendon. So when we do the physical exam to evaluate for injury to this area, we find that these dogs have excessive abduction of the shoulder. Now, it's really important to make sure you fully extend the shoulder joint and then put an abduction force on the shoulder. And not only will you get an increased shoulder abduction angle, but there's also going to be pain at the end of abduction. And that level of pain is what we use to help guide whether our therapy is being effective or not. That and the fact that the joints will tighten up. A lot of times the lameness that we see is intermittent. It occurs after physical activity, but if it's a very severe injury, the dog can be quite lame. Usually when we look at these dogs with an arthroscope, we can see the torn portions of the medial glenohumeral ligament, and sometimes we see a tear of the subscapularis tendon. With really extensive catastrophic injuries, that joint capsule can also be torn. So here's the abduction test. And if you try it today, when you go back to your homes and try it on your own dog maybe, if you just put the shoulder in a neutral position and try and do the shoulder abduction, you'll see that you can get that shoulder almost probably 80 degrees abduction. But if you fully extend the shoulder joint, you should reach a limit at about 30 degrees of abduction. If you have something more than that, like the picture on the right here, and there's pain at the end of that abduction test, then you probably have medial shoulder instability. Now, this is a radiograph of a dog with pretty severe medial glenohumeral ligament injury, but you really don't see anything because this is strictly a soft tissue injury. You can do an MRI on these, but in my experience, it underestimates the severity of the disease because I can see nothing on an MRI, but when I go in with an arthroscope, I do see some damage. If you do see damage on an MRI, then usually there's quite severe damage arthroscopically. It's difficult to impossible to image these with ultrasound because you really can't get the ultrasound head at a 90-degree angle with the shoulder structure. So there's a lot of artifact and improper interpretation of that area with ultrasound. So it really is a physical diagnosis and then hopefully following up with arthroscopic evaluation if possible. Most of the cases that we see with mild to moderate medial shoulder instability, we can manage non-surgically. It's very important to keep these dogs in hobbles for a period of time to prevent excessive abduction. So during that period of restricted exercise, we want no running, jumping, or playing, leash walks only. Kind of our go-to treatment is extracorporeal shockwave treatment. This is a treatment that is used quite commonly in equine practice, but we also use it quite a bit in our practice on dogs with any type of soft tissue bone interface problem. So ligament problems, tendon problems, and so forth, and also for osteoarthritis. So the shock wave is a high intensity sound wave that's transmitted through the tissues, reaches that interface, that soft tissue bone interface, releases its energy, and then that stimulates growth factors to be produced in the area by the cells that infiltrate and helps jumpstart the healing process. And then we keep the dog in hobbles, usually for a full month. We like to do 2 shockwave treatments, then place them in hobbles. We'll recheck them at a month. If we have loss of pain and the shoulder has pretty normal abduction angle, we'll start the dog into rehab. If not, if we still have excessive abduction and or pain, we'll do another shockwave treatment, and we may keep the hobbles in place for up to 10 to 12 weeks. After that, it's unlikely that conservative management is going to be effective, and we'll recommend surgery. So other exercises that we can do when the joint is comfortable and stable, we'll start some balance boards, some strengthening activities, weight shifting and so forth, walking in figure eights and circles, just trying to get the dog used to using the muscles to rotate that shoulder properly and stabilize it. And I think we have about a 75% success rate in those mild to moderate cases. If we have a severe case right from the beginning, or a conservative case that doesn't seem to respond, we can do what's called a tightrope procedure. With this procedure, we drill a tunnel through the proximal humerus so that one end of the tunnel comes out where the medial glenohumeral ligament inserts on the humerus, and then we drill another hole in the scapular neck and have the suture hole come out where the base of the scapular neck is, just in front of that acromial process. And then we pass a very strong suture material between the tunnels, and you can see we've got a tissue anchor on the scapular side, and then we've got a button on the humeral side that we can pass the ends of the suture through, tighten up the suture, and tie it to physically maintain that position. And this happened to be a dog that was an agility dog owned by a veterinarian. And within about a month, she said the dog was pretty sound. And a couple of months later, put the dog back into training and went back into agility competition and did quite well. Supraspinatus strains, we can have damage to the supraspinatus tendon, typically where it inserts on the greater tubercle. These dogs are often chronically lame. Some of them are quite lame and are almost non-weight bearing. It's less common than the biceps or medial shoulder instability, but it still can occur any age or any breed, but we tend to see it more in larger breeds, middle-aged type dogs. Radiographs may show some chronic changes, that being mineralization next to the greater tubercle of the humerus, and we can use, again, that Skyline view to help delineate the dystrophic mineralization of the supraspinatus muscle from the bicipital group where the biceps tendon runs. We can also have mineralization of the supraspinatus tendon and have it be physically present, but not cause any lameness or clinical dysfunction. So just because we have mineralization in the area does not mean it's the cause of the dog's lameness. We do see a number of cases that have had prior injuries and they seem to heal. When we evaluate these dogs, we want to stretch that supraspinatus muscle. So a little bit of flexion and adduction of the shoulder, and then palpating the tendon as it inserts on the greater tubercle. They also may have some pain with palpation of the biceps, especially if we internally and externally rotate the shoulder joint at the same time, because the supraspinatus muscle changes, the fibrosis and mineralization may impinge on the biceps tendon. We generally can diagnose these with ultrasound pretty easily, but also with MRI. Injuries are often bilateral, so we want to check both sides. And this is looking at that Skyline view. You can see the dots kind of outlining where the bicipital groove is, where the biceps tendon is, and all of that excessive bone production, that's mineralization of the supraspinatus tendon where it attaches to the greater tubercle. So you can imagine if you internally or externally rotate the shoulder, you may cause some impingement on that biceps tendon. And this is the radiographic positioning to get that view for the supraspinatus. And another view just showing the proximity of the supraspinatus with the area of the biceps. So to treat these conditions, it depends on how severe the changes are, but we found shockwave treatment to be very effective in early cases of supraspinatus muscle tendon injury. Laser therapy can be effective, therapeutic ultrasound, but I think the primary treatment that we would use is extracorporeal shockwave therapy, and then strengthening exercises, especially underwater treadmill therapy, to help restore muscle strength and function. We can also use platelet-rich plasma and stem cells for these injuries. And if they don't respond to conservative treatment, then we can do surgery to resect the torn or damaged portions, and perhaps even suture some of the damaged tendon back together. We can also tenodese the tendon. If we take out the entire area of the inflamed tendon, if it's not too long of an area, we can take that tendon and then reattach it to the greater tubercle. Now, the condition, unfortunately, can recur. So once a tendon is damaged, there's always some weakness of that area, and it can become re-injured. And in fact, some reports have suggested that dogs can have a poor surgical outcome, with 20% having poor outcome, primarily because of recurrence. This is a condition that's kind of fun to diagnose. There's really nothing else that will do this. This is an infraspinatus muscle contracture. And if you think about what the infraspinatus muscle is doing, and then contract the muscle, it's going to externally rotate the antebrachium and prevent the shoulder from extending properly. And that's exactly what these dogs look like. The whole lower limb is externally rotating, and they kind of use the lower limb, the paw, as a flipper. So this is what a dog can look like. This dog is not just posing in a pretty position. It physically cannot get the antebrachium turned around into a straight position because of the contracture of the infraspinatus muscle. And this is a video of a dog. And even going away, you can kind of see the characteristic paw flip on that left forelimb. And as the dog comes back to us, you can really see how the elbow gets internally rotated, the entire antebrachium externally rotates, and we have that little flip of the paw during the swing phase of gait. So that's almost pathognomonic for infraspinatus muscle contracture. So unfortunately, most of these cases cannot be managed medically, because by the time we see them, there's already a lot of fibrosis and contracture. So we transect the fibrotic tissue. It's important to make sure we release all of those fibrotic bands and free up the tissues. And literally, they're normal on the surgery table. You can feel a very distinct pop when you release the tissue. And then, of course, we want to do some rehabilitation to help prevent any recurrence of the fibrotic tissue. So this is a diagram of where that tendon is, so we can actually kind of do a muscle splitting approach where we pull that acromial head of the deltoideus caudally, and then we look right underneath that and we see the infraspinatus tendon. We want to make sure we remove all the fibrotic tissue in the band, so you can see the joint capsule right underneath, and then the teres minor muscle just distal to that. Sometimes that's affected as well, and we have to cut that tendon. And this is what it looks like intraoperatively. You can see the damaged looking fibers of the infraspinatus tendon. And then after it's transected, you can see the damage that's been done to the tendon. We're going to take that back down to a good healthy tissue and then provide good rehab immediately after surgery. And this is the before and after picture of that same dog. So the day after surgery, on the right-hand side, you can see how straight the leg is now. And although the dog will be lame for a little bit just from the surgical approach, they tend to recover very quickly and do quite well. Carpal injuries, we have a variety of carpal injuries that can occur. You see a list of things: flexor carpi ulnaris tendinopathy, hyperextension injury, superficial digital flexor elongation, and dogs that are doing a lot of high-speed work and jumping. You can have medial and lateral collateral ligament issues, tenosynovitis of the abductor pollicis longus tendon, where they're digging a lot in holes, things like Jack Russell Terriers. And then we can also have traumatic injuries to the bony structures of the carpus. We're going to concentrate on hyperextension injury. This is damage to the palmar fiber cartilage and the carpal ligaments. It is not a injury of the flexor tendons. That's a common misnomer. This is actually damage to those firm supporting structures of the carpus. And they stand in a palmagrade stance. They're quite lame. They often have a history of jumping down from a distance. And unfortunately, most of these require surgery in the form of an arthrodesis. Very mild cases might be able to be managed with an orthotic or a splint, but most of the time when that carpus is dropped more than, say, to an angle of about 230 degrees of extension or so, then it becomes a surgical issue. So if we look at the normal carpus on the left here, and then we've got a stressed view of the right carpus, you can see that there's more extension or hyperextension of the cartilage or the carpus. And you can also see that ulnar carpal bone is lifted off of the fifth head of the metacarpal. There's a little bit more space on the right-hand side. And so that's enough to indicate that there's some carpal hyperextension injury. So in that case, we did a partial carpal arthrodesis. We want to spare the main motion joint of the carpus, that being the antebrachial carpus proximally, but we do a surgical fusion of the distal bones, burr out the articular cartilage, place bone graft, and then a bone plate. Now moving on to the hind limb, probably the cruciate ligament rupture is the most devastating and common injury in sporting dogs. And because of that instability in the knee, they almost 100% will develop arthritis, which may be more important in limiting their career. We can also have meniscal injuries. Certainly the medial meniscus is commonly injured with ligament injury, but there appears to be little effect in the short term, at least on performance. Ideally, we would like to get these when they're partially torn because there'll be very little arthritis present in the joint, and they have the best outcome with surgical treatment and postoperative rehab. So we have a lot of advances in the diagnosis and treatment, but there's still so much we don't understand about cruciate injury. For example, the exact cause and pathophysiology is still unknown, although biomechanical influences, the slope of the tibial plateau, inflammatory mediators that are in the joint, chronic stretch, dogs being deconditioned and overweight, all of these contribute to degeneration of the cruciate ligament. But regardless of what the cause is, we need to consider how to stabilize the knee. There's a lot of complex interactions between the bone, the cartilage, muscle, and other soft tissues, and how those all interact, again, is not understood. Surgical techniques are continuing to evolve and help improve patient outcome. The results today are much better than they were 20 or 30 years ago. But I think what really makes the difference long term is the postoperative management, the rehab of the cases afterwards. If you think of professional athletes, if they tear their ACL, they don't just undergo surgery and then wait for a while and rest and then go back into sports. They go through an intense period of post-op rehab. And that's a very important part in developing joint position awareness, as well as muscle strengthening and helping to prevent future injury to the joint. So the most common procedure that we do to manage this is the tibial plateau leveling osteotomy, where we make a curved cut in the proximal tibia, and we can actually rotate that tibial plateau to a more level position and then hold it in place with a special bone plate and screws. And this particular procedure seems to give the best results, especially in sporting and working dogs with a combination of the post-op rehab program. And again, the earlier the better. If we can get these patients when the cruciate ligament is only partially torn and there's minimal osteoarthritis and there's no damage to the medial meniscus, they have the best opportunity for a near normal function. Notice I say near normal because we can't rebuild what Mother Nature put in there, but we can certainly do a good job. So usually we'll send them home the day after surgery, after they get a couple of rehab sessions in the hospital, and then they have home exercises to do. We provide them with anti-inflammatories and pain control. And then we start with controlled rehabilitation and leash walks. Often, if we keep the dog in the hospital, if they're a very important sporting or working dog, we may work with them for 4 to 6 weeks until they're pretty much back to normal. And during this time, we're doing intense rehab on them. But when we send the dogs home with the home exercise program, we're a little bit more cautious because there can be some inflamed tissues if the owners don't know what to watch for. So we do have to have good postoperative care. Patella luxation is a condition that does affect some sporting and working dogs. Medial is certainly the most common direction, but we can also have a lateral patella luxation. In this condition, let's take the medial patella luxation. There's some type of malalignment of the quadriceps complex. There can be abnormal angles of the femoral head and neck with the shaft of the femur, bowing of the femur, bowing of the tibia, and displacement of the tibial tuberosity, in this case in a more medial direction. And the quadriceps muscle, patella, and patella ligament all want to be in a straight line. So when the quadriceps muscle contracts, it's going to pull everything into a straight line. And if we have malalignment, it's going to pull the patella out of place, and we'll have patella luxation. So we need to reestablish that. The first thing I like to do is determine, is the groove, the trochlear groove, deep enough? And if it's not, then we have to deepen it. So what I tend to do is a block recession, where we make a couple of cuts just medial to the high ridges of the trochlear ridges, and then we'll take an osteotome and mallet and very carefully osteotomize that block of cartilage and subchondral bone. And then in diagram C, you can see that the piece of cartilage and subchondral bone is lifted out of the trochlear groove. And then we can further deepen the groove. We take and make a couple more cuts. We take the osteotome and remove another sliver of bone, as shown in E, and deepen the groove. And then we can replace the block of cartilage and bone, as shown in F and G. And that actually is quite effective in deepening the groove. We also want to realign the quadriceps mechanism, so we want to transpose the tibial crest. And this is probably the #1 reason why patellas luxate after surgery, is failure to transpose the tibial crest. So I do this in probably 99% of patella luxation cases, where we're going to do an osteotomy of the tibial tuberosity where the patella ligament inserts, and then we're going to rotate it. In the case of a medial patella luxation, we're going to rotate it to a more lateral position, as shown in C, and then we're going to hold it in place with a pin. Sometimes in a larger dog, we'll also use a tension band to hold it in place. And so that's going to realign the quadriceps mechanism in a straighter pathway. And then we're going to do a capsulectomy by removing the redundant tissue. So we do a lateral arthrotomy for a medial patella luxation, then we take a strip of joint capsule out, and then we suture it up to help tighten up that tissue. Iliopsoas muscle problems are things that we're seeing increasingly with dogs with chronic pelvic limb lameness, as well as sporting dogs. Remember that the iliopsoas is made up of the psoas major and the iliacus, and they come together as a common tendon and insert on the lesser trochanter of the femur. Now, the femoral nerve passes very closely to the kind of where those two muscle groups come together. And if we have some inflammation or hemorrhage in that area from damage or tearing of the muscle, it can potentially cause stretching of the nerve and potentially a neuropathy as well. It's increasingly recognized in dogs with hip pain, such as hip arthritis. And the pain of the iliopsoas is not often related to the osteoarthritis pain. Usually patients with just iliopsoas muscle issues have very mild lameness, but they can have reduced performance, difficulty rising, and so forth, and a very stiff gait. And the maneuver that we use to assess for iliopsoas muscle problem is we extend the hip joint and then simultaneously internally or externally rotate the hip. Now, if we do have hip dysplasia present also, those dogs will be painful primarily with hip extension. So what we want to do is take that hip to just before we get pain with hip extension, and then internally and externally rotate the hip. And if we have pain with that maneuver, we probably also have secondary shortening of the iliopsoas muscle, because the hip is not completely extending during gait if they have hip dysplasia. So the iliopsoas can be either primarily injured with sporting injuries, or it can be secondarily shortened because of other pelvic limb problems. And with that adaptive shortening, it can be painful with the iliopsoas maneuver. And if we have a true iliopsoas injury, the ultrasound can often help us with any damage to the muscle, such as fibrosis or hemorrhage in the muscle. So this is a dog that has iliopsoas pain, And what we're going to do is extend the hip and then externally rotate. And the dog really reacts. I've got the sound turned off, but the dog really yelps. And when I palpate the insertion of the iliopsoas on the greater or the lesser trochanter, the dog similarly yelps in pain. So both the maneuver as well as direct compression of that iliopsoas muscle at its insertion can help with the diagnosis. Usually conservative treatment of rest and nonsteroidals and gentle stretching and massage will cure most of these. But if we have more severe cases, we can do a transection of the tendon at its insertion on the lesser trochanter, and that helps to relieve the pain a great deal. We can have muscle contractures, primarily of the gracilis, but also the semitendinosus and semimembranosus. These are usually injuries that occur to the muscle, and then we have secondary fibrosis. And the gait is very characteristic for gracilis contracture. I'll show you a video in just a minute here. And we can also have gait abnormalities with semitendinosus contracture. These are very characteristic gait patterns. The German Shepherd dog seems to be the most commonly afflicted with these types of injuries, so there may be a genetic component as well. But as we watch this dog walk, you can see in the slow motion video how during the swing phase of gait, you see how there's that little quick hitch with an internal rotation of the toes and external rotation of the hock. That's because the gracilis muscle is contracted and doesn't allow the stifle and the hock to continue to reach forward. It's being limited by this very taut band. And when you see that kind of quick external rotation of the tarsus during the swing phase of gait, that again is almost pathognomonic for a gracilis muscle contracture. Now, most of the textbooks tell you that this is a very unrewarding condition to treat surgically. But we've had some success, some pretty good success, basically treating it like cancer, being very aggressive, taking out all of the fibrotic bands of that muscle, aggressively resecting them. Often you can't suture the muscle back together. There's not enough room, but sometimes to pull the tendons back together, the muscle tissue back together, but perhaps putting a fat graft in the area to prevent the formation of fibrous tissue, and then very aggressive in-house rehab for up to a month to help prevent that contracture from reforming, and then very carefully following those cases out for the next 6 months or so while that scar tissue is forming, but just hopefully not forming in a way to cause that contracture. So if we have recurrence, we need to aggressively manage those recurrences, again, either with conservative or surgical methods, hopefully conservatively. Damage to the common calcaneal tendon, that is made up of a number of different structures. They all come together at the tuber calcis. Most of the time we have acute injuries that are associated with traumatic lacerations, but more commonly we see kind of these chronic injuries due to some trauma, partial tearing and degeneration of the tendon. And physical exam, they stand with the hock in a drop position, and the toes will be pulled into kind of a crab-like position, very flexed, because the superficial and deep digital flexor tendons are still intact, but when the hock stands in a more flexed position, it puts more tension on those flexor tendons, and it pulls the digits into this characteristic stance in a flexed position while standing. And then you can also palpate thickening of the tendon. Hopefully the tendon is still connected. The worst situation is if it's completely transected and disrupted. Ultrasound can be helpful in diagnosing how bad the issue is. If it's a fairly mild injury, we can oftentimes treat those with stem cells and coaptation afterwards. But usually if the hock is standing at a more flexed angle, these are surgical cases. And this is what we see. You can actually see some bulging of the tendon where it's thickened here, and they also stand in a characteristic flexed position. So after removing or resecting the damaged portions, we can repair those with either a 3-loop pulley or a locking loop. I tend to use a 3-loop pulley technique. It's a little bit stronger. And then I'll follow that up with a bunch of smaller kind of locking loops around the edge of the epitenon. It gives it about 20 or 30% more strength. And then I manage these very carefully post-operatively, because if you just let the dog start walking on those, it's just going to pull the suture through. So I actually use a device. I have a transarticular external fixator that I put on with a ring on the bottom of the foot. So I actually will keep the foot suspended for about 4 weeks or so, and then I'll gradually start to raise the ring up to allow shared weight bearing between the apparatus and the toenails, and then the toes, and then finally the full foot, so that we're strengthening the tissue with biomechanical stresses, but not overcoming the strength of the healing tissue with sudden forces that will pull everything apart. So it's a very prolonged process, probably about 12 to 16 weeks. I have a dog right now that it's at the end stage of the rehab period. It's doing very well. And this dog had very severe injury. It was actually walking on the entire metatarsals and tarsus. And that dog is now standing pretty normally. So hopefully that dog will continue to do well. So we certainly don't want to overstress the healing tissues. Muscles require about 6 weeks for the adequate strength to develop, but tendons can take much longer to heal, only 80% of strength at 1 year. So this is a long-term management issue. Fortunately, for normal walking, only about 25 to 30% of their original strength is necessary for physiologic muscle contractions and walking, but we need to strengthen the tissue more to withstand higher speeds and additional activity. Foot injuries are also pretty common in sporting and working dogs. Pad lacerations, nail trauma is very common. They get the nails caught on obstacles. Most of these are treated by owners, but if we do have pad lacerations, then we probably need to close those by suturing them and bandaging them for a period of time to reduce the weight bearing and stress on the wound. So as you can see, as we wind down our time here, that sporting conditions are many. There are many different conditions, and also these conditions affect regular house pets as well. But for best results, we want to have early diagnosis, proper treatment, and realize that with sporting and working dogs, seemingly small problems can make a big difference in their performance. And just think of some of the professional athletes. They may not have a catastrophic knee injury, they may have a little bit of tendonitis, but certainly that can affect their elite performance quite a bit. And so we need to be very on our game when it comes to our orthopedic exam, really carefully palpate, evaluate for any painful areas, any swollen areas, joint effusion, because the earlier we can catch problems, the better the outcome that we can expect. And again, if you're interested in learning more about different causes of lameness, you can go to mylamedog.com. And in about 2 weeks, we'll have the other website up just for veterinarians, mylamedogsvet.com, which will have a series of courses to help improve your diagnostic skills for lameness and orthopedic conditions. And if you're interested in rehabilitation, we also have the Certified Canine Rehabilitation Practitioner Program as indicated there with the website. So with that, I'll turn it back over to our host and see if we have any additional questions.
There was a wonderful presentation, sir, and we have a lot of questions, that's for sure. But first of all, I have to tell you the feedback that we have received. I mean, let me just make a very quick run at it. Well explained, doctor. Thank you for organizing such an informative webinar on orthopedics in this pandemic. Thank you, sir. Then very nice and informative presentation by Dr. Balaji Ambore. Very nice presentation and informative from Dr. S. Yogesh Priya. Thank you for such a nice presentation by Dr. Akhtar Rasool. Very informative and useful session, sir, from Dr. Namrata Otalwar. And from Shobha Zavre, she's associate professor, sir, at Jabalpur Veterinary College. She says, thank you for very informative and interesting presentation. Thanks a lot. There's one from Dr. Satyavan Agevile. He's assistant professor. He also says of surgery. He also says, thank you for such a beautiful seminar, Dr. Millis. Thank you for And okay, rest is for us. Mohini Sharma says, thank you, sir. Very informative session. Dr. Deepak Kaushik says, awesome presentation. Sagar Chandra says, excellent presentation. Very informative and detailed lecture by Dr. Amandeep Singh. And one is anonymous. They say that excellent, because there were so many videos also where we could really see what was happening. Dr. K. Ashokan from Tamil Nadu says, excellent presentation. There's so many of such messages, sir, but this is just the one that I could quickly have a look. One of the questions that we have received from almost everyone, even yesterday also, is like, since the presentation, both the yesterday as well as today, have been very informative, they all would like to have access to the video of this recording, so that they might be able to go through this again, maybe, because not all the cases are available every time. Maybe they will encounter some cases and they would like to refer to this. So if it's possible for you to give us the permission, then maybe we can upload this video to YouTube and share the same with them, sir.
Yes, for sure.
Wow, sir, that's a great relief, sir. I'll certainly, all the participants must be really happy, and I'll certainly do the edits. I'll make them available by tomorrow, and I'll also send the emails to everyone. Getting back to the question, sir. From Ipsa Sharma, what can an owner do to their dogs if they cannot afford rehabilitation? Some effective ways of rehabilitation that a common man can do, in emergency cases, sir?
Yes, it's a matter of carefully following patients, but we incorporate a lot of home exercises, and some owners are coming from a distance away, or maybe they can't bring the dog in on a regular basis once or twice or 3 times per week. So we do send them home with home exercises. There is a program that you can develop your own home exercises. The website is canineexercisesolutions.com. And in that website, you can design home exercise programs for owners. And these are owner-friendly exercises, things that they can do with, regular household equipment, whether it's cavaletti rails or sit-to-stands or slow leash walks, hill walks. And you can prescribe the amount of time, the number of repetitions. There are instructions for passive range of motion and stretching, for example. So those are all quite valuable to use in the home environment. Or you can design your own exercise sheet where you explain. But I think it's very important to have some type of training session with the owner to show them specifically how to do the exercise, especially if it involves any range of motion or stretch, and have them demonstrate the exercise to you so that you can correct any misplacement of the hands or how they're doing the exercise. Were you able to? Okay.
Yes, sir. Next question from Dr. Gigin. In surgical corrections of orthopedic injuries in dogs who are growing at a fast stage, what period of immobilization is recommended so that we won't be facing the disuse atrophy conditions?
That's a good question, because we're going to start to get changes to the muscle tissue within, 10 to 14 days. We'll get changes in the cartilage within 2 weeks with immobilization. So in general, the shortest period of time possible is recommended. Now, sometimes we're treating a fracture with a splint or a cast. And so we have to make sure that the fracture is adequately healed. Otherwise, it's going to just refracture with weight bearing. So we really have to balance what we're trying to accomplish with the splint or the cast with what's happening. So we treat the primary problem first. And if it's a fracture, we treat that first, allow it to come to clinical union, and then we start to mobilize the soft tissues with stretching, massage, other techniques to help restore function. We're going to have a period where we have muscle atrophy that's unavoidable, but what we have to do after the fracture is healed is to begin strengthening exercises. And that can take, 2 or 3 times longer than the actual time taken for fracture healing. Other tissues, tendon injuries and so forth, it's a similar process. We want to make sure that we treat the primary problem first. If we have, say, a tendon laceration, treat the primary problem first, let it get strong, and then start the process of gradually introducing strengthening exercises.
Another question from Dr. Pathan Mohsin Khan. It seems he has been using some of the methods that I'm going to say. Are the following methods can be used in rehab, such as targeted pulsed electromagnetic field therapy, transcutaneous electric nerve stimulation, platelet-rich plasma injected into an arthritic joint? And he says that it has given good results to him. What is your opinion on these?
Yeah, we'll start with PRP in the arthritic joint. I think unquestionably there's a benefit to doing this, and we use it in our practice quite frequently. So in the literature also shows that there's a positive result with improved lameness, less inflammation. So I think PRP is valuable to use for a number of things, not just the ligament conditions that we talked about, but also for osteoarthritis. TENS treatment, transcutaneous electrical nerve stimulation, is a technique where we place the electrodes over a painful area and then have a bunch of low intensity electrical signals which take advantage of the gate theory of pain. So you're constantly flooding the spinal cord and peripheral nerves with a lot of less painful signals. The spinal cord can only handle so many impulses per second. So you're hoping to block out the transmission of the larger pain signals. And it's kind of a mild buzzing type feeling if you try it on yourself, or a pins and needles sensation. But that can be effective in alleviating pain for 4 to 6 hours, at least arthritic pain. So we use it quite a bit postoperatively, but you almost have to use it at least daily in order to have it be effective long term for, say, arthritic patients. And we'll have a paper coming out very shortly that discusses that, I hope. We've done the research, we're just submitting it to the journal now. The other one about pulsed electromagnetic fields, I think the jury is still out on those. I think there is some benefit. They are approved for use in pain management after surgery of certain conditions in people. We actually have a study going on looking at dogs with TPLOs, looking at bone healing, limb use, lameness, and so forth. I'm blinded, so I don't know which dogs are in which group, but I don't see a dramatic difference, so I'm not sure that there's going to be a huge difference in outcome. But it has been looked at in a couple of different things to help with pain after hemilaminectomy, for example.
Okay, so one question, sir, from Dr. Priyanka Thakur. She's assistant professor at College of Veterinary Science, Amritsar. What is the success rate of correction of hip dysplasia with the help of stem cells? Are there any studies that have been done?
Yes, there are a number of studies that have looked at stem cells for arthritis in general, but in particular with hip dysplasia, and they do provide benefit. They do provide less pain, improved lameness, just like the PRP. I think the big thing is the cost and the cost benefit. You get a benefit from both PRP and stem cells, but at least here in the US, there's a huge difference in the price. PRP may be $350 to $400, depending on the clinic or the type of PRP system that you use. Whereas to do stem cells here, it's about 25 to 2,800 US dollars. So there's a huge difference in the cost. I'm not sure that the difference in outcome is big enough to make up that difference, because after about 3 to 4 months, the effect of the stem cells begins to wane, and re-injection, although it's not going to be that costly every single injection, because after you do the initial harvest of the fat, you can store aliquots of stem cells. Depending on how many stem cells the dog has, you may have anywhere from 4 to 8 aliquots, and you just have to thaw the cells out and inject them again. So it's not going to be the same cost every time that I mentioned, but it does need to be re-injected periodically. And the more severe the lameness, in my experience, the more frequently you have to re-inject. But it's not going to make the arthritis go away. The object is not for the stem cells to resurface the cartilage or to regrow the cartilage. It's resetting the inflammatory pathway. So, normally there's going to be more catabolic processes going on than anabolic processes in the joint. And what you're hoping to do with stem cells as well as PRP is to kind of level the anabolic and catabolic processes.
So can we take 2 more questions, sir? I understand we are way over the time.
Okay.
Thank you, sir. There's another question from Dr. Ambore, sir. He's asking, he do get to see a lot of cases of chondromalacia patella. What are the curative treatment of measures? Those are being usually employed in America. Is there something new that can be tried?
Well, I think there's, when you talk about chondromalacia of the patella, I'm assuming that's going along with luxating patella, because we see quite often abrasion of the cartilage down to subchondral bone. And so we do see that, and we just have to try and do the correction of the patella luxation. There's nothing really that we can do to regrow the cartilage, although in some cases, drilling a bunch of very small holes in subchondral bone can allow blood supply to come through and hopefully resurface with some fibrocartilage. Now, it won't be normal hyaline cartilage, but some type of cartilage. Fibrocartilage is better than raw subchondral bone, so that may be a technique that could be used. But in terms of the typical chondromalacia that people get, for example, where there's anterior knee pain, that I think is relatively uncommon in dogs. I would look for other things like partial cruciate ligament rupture or a grade 1 or grade 2 patella luxation. It has been reported, but in my experience, it's pretty rare.
Another question from Dr. Shobha Zavre. She's associate professor at Jabalpur College, sir. She's asking, what about intra-articular medication, especially in arthritic cases? Are they really recommended in the initial stages, or should there be a stopgap before going to them?
Yeah, I think I would look at intra-articular therapies as either biological therapies or as pharmacologic therapies. So the biologic therapies would be things like PRP, stem cells, and hyaluronic acid. And then the pharmacologic treatments would be more in line with intra-articular steroids. My approach to managing arthritis cases is to use the biologic therapies earlier in the course of the disease, because you're hoping to protect the cartilage. So in order for a chondroprotective agent to work, there has to be some chondro to protect. So I would rather be more aggressive with the biologic therapies early in the course of the disease. Now, at some point, some of these dogs are going to get such severe arthritis that biological therapies may help, but they're fairly short acting in terms of their effect. And so we may need something a little bit more potent. And in those cases, intra-articular corticosteroids can work. Now, we're talking about bone on bone. The quality of life is being greatly affected. You've tried all the other simple things, and they're just not having the effect anymore. And so we can inject intra-articular steroids aseptically. And there's a difference in steroids. Triamcinolone seems to be the best for cartilage in terms of minimizing the effect of cartilage. Other types of steroids, although they're effective in improving function and reducing inflammation, they also can be damaging to the cartilage. So we try and use triamcinolone whenever possible for those. But that's only in end-stage cases.
There's one last question, sir. Which sport you have seen? It causes maximum injuries. What kind of sports?
Oh, what kind of sports causes maximum injuries? Wow.
Or activities.
Yeah, so I think agility has a lot of injuries that occur. And I think also field trial work as well. Those would be probably the two most common that I see. Police dogs, also we see a number of different things there, just because those dogs are so high drive and they're aggressive, they're jumping a lot, they're constantly up on their back legs sniffing for drugs or, you know, in the attack position. So we see a lot of lower back problems with police dogs and military dogs, which, by the way, you can strengthen those back muscles and help to alleviate some of that pain and discomfort. But I think shoulder injuries we see more commonly in agility dogs and flyball dogs. We probably see more cruciate injuries and tendon problems and foot problems with field trial dogs, hunting dogs, and then the lower back problems and iliopsoas issues with police dogs.
Thanks a lot, sir, for answering this question. I still see at least 30 to 40 really good questions that I can put forward to you. But since the time is, and you also have other engagements to go to. So, sir, I guess we'll call it. And thanks a lot, sir, for your time. And it was a wonderful presentation. I'll let Dr. Shalaka handle the rest of the function, sir.
Okay, thank you.